You are now listening to MedEd Talks Primary Care, a Vindico Medical Education production. The following podcast series is titled Expert Weigh-In Podcast Series. To earn CME credit, log into mededtalks.com and search Expert Weigh-In, or click the link in the notes section of this podcast to go directly to the activity, take the test, and complete the evaluation. Before beginning this activity, please be sure to review the faculty and the learning objectives. Now, here's your host, Dr. Robert Kushner.
Hello, I'm Robert Kushner, professor in the departments of medicine and medical education and former director of the Center for Lifestyle Medicine at Northwestern University Feinberg School of Medicine in Chicago, Illinois. I'll be your host for this exciting new podcast series titled Expert Weigh-In. In these podcasts, I'll be interviewing physician experts on various topics in obesity management. In this episode, the role of pharmacotherapy in comprehensive obesity management, I'll be speaking to Dr. Lou Aronne. Dr. Aronne is the Stanford I. Weill Professor of Metabolic Research and Director of the Comprehensive Weight Control Center at the Weill Center for Metabolic Health in New York, New York. Welcome, Lou.
Thank you, Bob. Pleasure to be here.
Today, we'll be discussing the role of pharmacotherapy in comprehensive obesity management. You know, Lou, I'm hard-pressed to think of anyone else who's better suited for this podcast than you. We've known each other for decades, and you've been a leader in the field in so many ways, particularly when it comes to the role of pharmacotherapy. So let's get started with the first question. Our understanding of the pathophysiology of obesity has absolutely exploded over the past several decades or so. How has this new information influenced the development of novel pharmacologic agents?
That's really a great place to start. And I just want to say that I thank you for having me on, Bob. You and I go way back. And, it's been great working with you. And I look forward to continuing to working with you over the years. So, when you think about it, when I got interested in obesity back in the 1980s, we looked at it as purely a behavioral problem. And it was just a lack of willpower. And there were a couple of things that profoundly influenced me in the 1980s that changed my opinion and made me realize that the way to successfully treat obesity once it was established was with medical therapy or surgery, that we needed something physical to do it. And the reason was that obesity had a power physiology. And the two most important things were, number one, seeing the animals that were being bred at Rockefeller University, who the gene for leptin was discovered in. Right? At that point, we didn't know what was going on. But one of the researchers over there, Dr. Rudy Leibel, showed me that if he transfused blood from a thin animal into its fat brother, the brother went down to normal weight within 3 days. I mean, I couldn't believe it when I saw this in 1987. And he said, well, there's something floating around in the bloodstream of the thin animals, and the animal with obesity doesn't have it. And as soon as we give it back, the body re-regulates to the weight of the thin littermate. And that was really a wake up, like, wow, there is something else going on than we think right here. And that was really the first step that shocked me into realizing that I had an interest in obesity, but that really changed my career. Another thing that profoundly impacted me was a discussion I had with our chief of cardiology here at Weill Cornell, and his name was Dr. John Lara. He is credited with developing the field of hypertension treatment. And he told me when I explained what was going on in obesity, he said, back in the 1950s, people told me that hypertension was just a psychological problem. People were under stress, their blood pressure would go up. And if you took the stress away, then the blood pressure problem went away. But I realized that if we could control the physiology of blood pressure regulation, then people wouldn't have hypertension. They wouldn't develop heart failure, kidney disease, stroke, all of those complications. So he advised me not to listen to anyone else and to keep doing what I was doing and see if we could figure this out. I didn't realize it was going to take so long to get to this point, but I'm glad that I stuck with it.
Yeah, of course, what you were talking about early on is the discovery of leptin, which is that adipocyte brain connection, but that didn't work out so well. But what we now have is the gut brain connection. And in that light, everyone knows what GLP-1 is or heard of it, like Kleenex. I mean, like everyone's heard of GLP-1, but I'm not sure everyone really understands what it is and how it works. I wonder if you can describe the mechanisms of action of GLP-1 receptor agonists when it comes to obesity treatment.
Sure. GLP-1 agonists are compounds that simulate the effect of naturally occurring GLP-1, which is a gut hormone. GLP-1 is released when you eat food. It goes to your brain, it goes to your pancreas, it goes to other tissues, like other parts of your gut, and it signals basically that you've eaten. That's one of the things that it tells you. And as a result, it reduces your drive to eat more. It also may slow down the passage of food through the intestine and maybe even through the gut. So it's a key signal that you've eaten and helps you to process food properly. And when it first was discovered, the problem was that it lasted for only a minute or two. So in doing experiments early on, back in the 1980s, by the way, GLP-1 was discovered well before leptin. The problem was that it lasted only minutes. And so an intravenous infusion had to be delivered to people in order to see any effect. But we knew that it could have an impact not only on blood sugar, but also on food intake.
And of course, just to add to that, GLP-1 is an incretin hormone, was originally used for diabetes. That's kind of where it got its claim to fame and then moved on to obesity. But there's also another incretin hormone called GIP that's less well known, I think, and it is a component of another medication on the market called tirzepatide, which is a GLP-1 GIP dual receptor. And I wonder if you could talk about the difference between semaglutide, which is the GLP-1 monoagonist, and tirzepatide, which is a GIP GLP-1 dual agonist. Is there a difference in efficacy and tolerability between these two medications?
Sure, they are very different. A lot of people use the same terminology, GLP-1 for both, but as you pointed out, they're very different. Semaglutide is a very potent GLP-1 agonist. It's at least 4, maybe 5 times as potent as native GLP-1 in stimulating the GLP-1 receptor. On the other hand, we have tirzepatide, which is very potent as a GIP agonist, but it's very weak at the GLP-1 receptor. It's about half as potent as native GLP-1. It's very hard to understand completely what's going on with the combined GIP GLP-1 agonist, because if you give GIP alone, it tends to cause weight gain and also reduces nausea. So when you give it to humans as an infusion or as pure GIP agonist injections, we see increased food intake and an increase in appetite. But when you give it with GLP-1, you tend to get a reduction, not just tend to, you get a profound reduction in food intake. You also get metabolic effects. GIP, as opposed to GLP-1, has direct effects on the fat cell and appears to increase lipolysis. And that may also reduce appetite and have an independent effect, helping with weight loss. So they're actually pretty different medications. But the thing that has impaired the development of GIP active drugs is the observation that GIP alone causes weight gain and increased food intake. So, when you look at, and when researchers were looking at these GIP, GLP-1 combined compounds initially, people said this can't possibly work because the GIP alone would cause weight gain. But after doing, I mean, this is where I come from when I say you got to do the experiment to see what's going to happen when it comes to obesity treatments. And sure enough, we have the most effective drug. So where the pure GLP-1 agonist, semaglutide, produces about a 15% to 16% weight loss in the phase 3 trials, what we've seen is about 20 to 22% weight loss with the GIP GLP-1 combination. And recently we did a head-to-head trial and we saw a similar magnitude of difference, about a 6% difference in weight loss with the GIP GLP-1 agonist having a greater effect.
Right. So there's something else going on there, adding the GIP.
Mm-hmm.
So Lou, the bottom line here regarding current treatment of obesity is we're taking these naturally occurring gut hormones, manufacturing them, and giving them back to people at very high doses, which affects appetite. Here's the question, Lou. Do individuals living with obesity have deficient levels of these hormones? Is that why they're so effective when we give it back to them? Or they just need higher levels and they respond to their natural levels of these hormones?
That's a great question. We know, so these are hormones that respond to food intake. And we know that the response to food in people with obesity is blunted compared to normal weight people. So people with obesity have been shown not to produce as much. But if you do bariatric surgery, you see far greater production of these hormones. So in certain ways, these medications replicate what's going on physiologically when you do bariatric surgery. The amount and the prolonged stimulation of the receptors is new, however. That doesn't happen if you have bariatric surgery. I mean, the levels go higher, but they don't stay higher for hours, days on end, the way they do with these medications. So in certain ways, we're exploiting these to get pharmacologic levels that may be doing different things than they originally did. One thing I'll point out, as you well remember, I mean, we've had GLP-1s around for 20 years. Exenatide was the first. And so why didn't we use exenatide as a weight loss agent? And believe me, we tried. But what we found was that people would get nauseated and have gastrointestinal side effects before they would really lose weight. And then another compound that came out, which was the first once weekly compound, dulaglutide, that caused a terrific improvement in blood sugar. It also was shown to reduce cardiovascular risk, but it didn't produce much weight loss. So it's possible that you can differentiate these, and we're still beginning to understand why it is that some of the compounds like semaglutide and tirzepatide are so effective at reducing body weight.
Yeah, that's absolutely fascinating, and it is ongoing science, as you just said. We're learning something every year. Let me change gears a little bit to more of the outcomes of these drugs. We don't really, Lou, you and I and others don't think of these as weight loss drugs anymore. We never use that language. We talk about improving health. And the question to you is the improvements in health that we're seeing and all these complications and comorbidities, are they due to the weight loss of these highly effective medications, or do they have weight independent effects as well? Sleep apnea, heart disease as examples.
Well, that's another very interesting question. And to try to solve that, we've done something called a mediation analysis in several of the trials that have been done looking at tirzepatide, the GIP GLP-1 dual agonist. And what we've seen is that while the majority of the effect seems to be related to weight loss, there is a significant effect that is independent of the weight loss. And, these are statistical methods to where they're looking at people who didn't lose much weight and, what's their improvement in risk from the cardiovascular parameters. And there is improvement. And again, we've known this for some time, that even people who don't lose much weight, even people who don't have severe obesity, we've seen benefit from drugs in these categories. So I think that that is one of the really exciting stories that's been going on where, both GLP-1 and GIP, GLP-1 dual agonists are turning out to show improvements in the key thing is in inflammation. And an inflammation where we haven't been able to reduce inflammation easily before. We've seen, for example, high sensitivity C-reactive protein go down 60, 70, even 80% in some of our trials. And that's a reflection of inflammation elsewhere in the body. I don't know if you've seen a case like this, but we now have a collection of people who were people with significant obesity and rheumatoid arthritis who were on biologics for their rheumatoid arthritis. And what the patients have found is that they don't need to take their compounds as frequently. So initially they spread them out. So something they used to take every week because they were getting pain in their joints, they started taking it less frequently. And in some cases, not all, but in some cases, they've been able to wean off these. So this is, clearly both a direct and indirect effect, but really an amazing change in the way we manage these problems.
Yeah, absolutely. And you and I know there's been over 200 medical problems or complications seen with obesity. So this can really change the entire landscape, the paradigm of how we treat individuals with obesity with these medical problems.
That is the power that you and I have always talked about of treating obesity, is that you get everything. I still joke about it when I give lectures and say it's like one of those late night infomercials. Not only do you get the Ginsu knives, but you also, get the little blender and, you get it all
Right.
for one low price. I mean, that's what happens when you treat obesity. So not only do you get the reduction in cardiovascular risk, but you get the improvement in mobility, in arthritis, in low back pain, in arthritic symptoms of all types, fat in the liver. So you reduce the risk of developing cirrhosis, sleep apnea. I mean, the list goes on and on. And
Yeah.
now we have treatments that are effective enough to see this. Like we see this every day. Every day when we see patients, people come in and say, I don't know what's going on here, but this got better. So I had a patient last week who told me, I went to see my dentist, and my dentist said, oh, you always had bleeding gums and, you're having a lot of periodontal inflammation, and it's gone. It's gone. I don't know what happened. I've never seen this before. Is that related to taking one of these drugs and the weight loss and the reduction in inflammation? I don't know, but that's where we're really beginning to get insight into what's going on, how reducing inflammation in many parts of the system can be very, very helpful.
Yeah, absolutely, Lou. Agree completely. It takes me to my next question, which is really more clinical and in the clinic, as we say. There are at least 5 other medications available for treatment of obesity approved by the FDA beyond the incretin-based hormones that you and I are talking about, incretin agonists that we're talking about today. What other factors help clinicians out? Put on that primary care hat. How should clinicians be deciding upon which medications to be recommending or offering their patients who come in living with obesity and having medical problems?
Sure. And I think you bring up an extremely important point, which is that not every person who walks in the door of an obesity treatment center should be getting the most expensive, newest medicine the first day they get there. And the approach that we take is one where we try to evaluate the risk of the disease, the possible complications for the patients, the cost of the treatment. And we will stratify patients. So someone who's very low risk, so that would be a younger person, someone, let's say, below 35 with a BMI in the lower 30s, we would almost always start with one of the less expensive oral medications. Could be naltrexone bupropion, could be topiramate, phentermine. We even use medications like metformin off-label. We would start with medicines like that in lower risk patients. Why? Because we have some time, like nothing bad's going to happen immediately. And if they have side effects, they can generally tolerate them very well, and we can stop the medicine and do something different. As opposed to older people, people who have cardiometabolic risks, someone with diabetes perhaps, or chronic kidney disease or fatty liver disease, we would tend to use medicines that have a proven effect in those other disease states. That doesn't mean that the older medicines won't work, but that's how we have stratified patients. And what we found is that about a third of the people who come in to be seen can utilize and will be successful on the older medicines. And this, in working with large companies and trying to control costs of healthcare, what we find is that they are very open to these ideas. The idea that you're going to stratify people, and someone who is low risk, we're going to give this, but if it doesn't work, we're not going to give up. We're going to go to the more expensive medication. That is a strategy that they're very excited about, because we've shown that we can dramatically reduce the cost of delivering care. I mean, we have a company is delivering care in a large way through telehealth to employees of the state of Connecticut. And we just had a white paper come out from a third party, Milliman, which evaluated this program and showed substantial savings above what was going on before, when everybody who came in, so originally everyone who saw a doctor got a GLP-1 or GIP-GLP-1 agonist. We've been able to show that a third of the people didn't need it, but still lost 10% or more of their body weight. The mean weight loss we got was 16% in this program. And again, many of the people were not on the GLP-1 and GIP-GLP-1 dual agonist. So it's very, very important for physicians to know that it's not just everyone who comes in gets the exact same thing.
Right. And the way I usually talk about it, to add on to yours, is it's really not that much different than other medications. It's complications, contraindications, route of delivery, patients' preferences and goals. Cost always comes in there, and clearly the costs need to come down.
Sure.
Lou, I want to turn to, I think, one of the most interesting controversial topics in our field these days, and I think for clinicians as well, and that's the role of lifestyle management in this new era of highly effective medications. So what would you advise to the primary care clinician who, let's say, is using a highly effective medication? Do they need to talk about lifestyle management? If they do, what should they be doing? How worried should they be about losing weight?
Sure. So what our lifestyle management has changed to from where it was. So back in the old days, we focused a lot on counting calories. Honestly, we don't focus on that nearly as much anymore. Some people want to, some of the patients want to, that's great. What we focus on is the quality of the diet and making sure that people are on a high quality diet. So one of the big issues is protein intake, because what we see is that when people reduce all of their food intake, it's well documented that there's a reduction in lean mass that is about 25 to 35% of the total weight that's lost. We want to minimize that. We want to minimize lean mass loss and maximize fat mass loss. And while we're working on compounds that will do that, believe it or not, there are a couple of them that are coming through and will make it to the clinic in the next few years, I believe. For now, what we have to do is increase protein intake, and that will tend to minimize the loss of lean mass. There are studies, older studies without these medicines, showing that it is possible to reduce that loss. Focusing on resistance exercise, that will also minimize the loss of lean mass. Making sure that people eat their vegetables first, so that we know you've eaten vegetables if you've eaten them first. and then going on to proteins and carbs towards the end. We've done studies showing that that lowers glucose and can actually be a diabetes prevention strategy by itself without medication. So that's been the kind of counseling that we have recommended, and I think is still very important. So, I'm sure this happens to you as well. As kind of the obesity management center of last resort, get referred tough cases. And so, people call me all the time and say, "Hey, you're so smart about these drugs. Here, go look at this guy." And, they'll send me someone who's lost 15 pounds taking tirzepatide when we know that he should have lost, 75 pounds. And then we have to try to figure out what's going on. And, in some cases we can. We see that, they're taking four. That's, one patient was taking four medicines that caused weight gain. And when we changed that regimen, they started losing weight. It was like, wow, who thought this could happen? But many of them don't. And we have no idea why that is. We still do not completely understand why we have enormous responders and then relatively non-responders. We're getting to a point with the next generation of drugs like retatrutide and several others where we're seeing 100% of people lose 5% or more of their body weight. 95% lose 10% or more of their body weight. But it's not like everybody loses 15, 20, 30% of their body weight. So, while the curve continues to shift towards greater weight loss, there are still people who don't respond, and we don't completely understand why that is. So here's my belief that if we focus on diet in those people, we're going to get a better result. And we have gotten a better result. So there may be something about food that overcomes even the most powerful drugs, that it does something to body weight regulation. When you look at, ultra processed food, it may interfere with signaling pathways in the brain and other physiologic processes that make the medication not as effective. They sort of neutralize the effect of the medication. And again, we have seen patients who were not responsive, who then began to respond when we were able to get them to comply with the kind of diet I'm describing. But the other thing is we don't have a single dietary recommendation for everybody. I think a lot of people are doing this. We're very flexible. If someone wants to do intermittent fasting, that's fine. But everybody shouldn't do intermittent fasting. Some people, they're like, I can't deal with that. No problem. Let's do something different.
Yeah, your points about diet are fascinating, and it's really reimagining, right, dietary counseling in the clinic, what these new medications are bringing forward. Bottom line, though, I think you and I both agree, don't just prescribe the medication, right? Give
Right.
counseling and support of how to best use it when it comes to that lifestyle and diet and physical activity. Lou, we have just a few minutes left, and I want you leverage your experience and knowledge in this field. What do the next 5 years look like? What is exciting to you, and what should clinicians be looking for in the development of newer medications in obesity care?
That's a great question. There are dozens of new medicines, many with new mechanisms of action, which are going to be coming down the pipe. I mean, currently, a number of companies are in a drag race to get the most weight loss. And, that's terrific. And so maybe the 9% of the population that has a BMI of 40 and above, we will be able to treat them with increasing efficacy, and that's fantastic. But we also have the vast majority of people with obesity and complications who don't need to lose massive amounts of weight. And so there are a number of other compounds in development that have totally different mechanisms of action. They don't cause nausea the way these drugs do. They don't cause other gastrointestinal side effects. So we need new compounds that work in different parts of the brain and other areas so that we can, number one, have greater efficacy in people who don't respond, and number two, that have different side effect profiles that we can, number one, treat people who can't tolerate these, which, it's not that it's big, but it's not zero. And we're all stuck with those people, so we need those solutions. So I think those kinds of solutions are coming down the pipe. I see them, moving from phase 1 into phase 2. But someone recently showed me a series of slides documenting more than 60 compounds in development, and there were many different mechanisms.
Right. I just want to add, Lou, is that there are oral medications, I think an important thing for the clinicians and patients, right? We call them small molecules that you'll be able to take every day with or without food that may have the same action as the weekly injectable. No, other options for patients, right?
That's right. They'll also, that's very, very important point. And also the small molecules should be less expensive to make. They don't need a cold chain, which should reduce the price even more. They don't need refrigeration. Distribution can be a lot wider. I mean, those will be the advantages. But then there are also medicines that are going to be available once a month. Once a month. I saw recently a once a week oral medicine. How about every 3 months? How about things that seem to have prolonged effect over months and months? Those kinds of things are, possible. Can obesity be cured? I always bring up a study we did 20 years ago where we actually cured obesity in animals and in humans. And the treatment, is not too complicated to be available now. But it worked, and it shows that it can be done. And in the future, I think that people say, "Oh, do I have to take this every week for the rest of my life?" Well, maybe now for the next few years, but eventually, I think we're going to be using these medicines to get down, and then using them or other medicines intermittently to maintain the weight loss and the good health.
Well, stay tuned to an exciting area. Lou, thanks so much for your insight and excellent discussion, and thank you for listening. Please remember to take the post-test and evaluation to receive CME credit and to tune in for additional episodes within the podcast series.
Thank you for listening to MedEd Talks Primary Care. Just a friendly reminder, CME credit can be claimed through mededtalks.com. For other episodes in this series, search for Expert Weigh-In Podcast Series.